Well, Neil, thanks for coming along today.
Thanks for inviting me.
We're very happy to have Dr. Raskin here. Tell me about your neurology background. I mean, you've told me a little bit personally, but would you be able to enlighten me and the people watching this as to how that occurred?
You hear this all the time, that you have to be in the right place at the right time.
Yes.
So, and that's what happened to me. I was a research fellow at Columbia after my residency, and my mentor that year was Robert Fishman.
Oh yes, Dr. Fishman, I recall him well.
Who was one of the bright lights at Columbia at the time.
Yes.
And he was being recruited by a number of medical schools to be chair of neurology there. UCSF was one, Rochester was one, and Southwestern in Texas was the other. And I was kind of hoping he would get the San Francisco one.
Yes.
In any case, I moved on from there to the NIH. And when I was there, he rang me up and said, I got the job at San Francisco. You got a job if you want it. So that was great for me, because most of the guys at NIH are working real hard to churn out papers so they can go out and give a talk at Grand Round somewhere and get offered a job.
Yeah.
Here I got offered a job the first year I was there.
And you have been involved for years with the American Headache Society, previously called the American Association for the Study of Headache, which was really a rather interesting name for an academic society, which back then was predominantly clinical, correct?
Yes.
And you were actually the president of the American Association for the Study of Headache, and I believe from 1994 to 1996.
Exactly right, yeah. It was started by a bunch of people who had not only no scientific backgrounds, but they weren't specialists. Most of them were just general medicine guys who kind of were interested in headache.
Tell us about your career trajectory, because you began, as you say, with a group of non-specialists getting together, asking simple questions, and now you've scaled the height of the field. Has there been anything that has changed that over time?
Well, I think the field has become more scientifically grounded.
Yes.
And I think the discovery of sumatriptan and its introduction in the early 90s, I think, it just galvanized the whole field.
Yeah.
It got people away from the simplistic ideas of blood vessels pulsing and constricting, and helped move people along to the idea that this is a brain-derived problem.
Now tell me about the great clinical entities you described or expanded our knowledge on.
Tell patients when they ask the why question.
Oh, yeah.
First of all, I'd say, I really don't know any answers to why questions anymore. I thought I used to, but I don't. Yeah. But I think the why question for benign headaches that are not based on a structural abnormality of brain, I think the why is a computer error. I think that there are some cells in our near perfect computers that just start misfiring, and I think that's what headaches are about.
Wow.
I spent a year in the Navy in 1965.
Yes.
And I got barraged with headache patients, because in the military, that's what you do as a neurologist. You see people with headaches. Like 80% of the people I saw had headache as their problem. And I had never been exposed to headache this way. And among those people, several of them talked about their headaches, terrible headaches they got eating ice cream quickly. So when I got here to UCSF, I had a medical student who wanted to spend a summer doing research, and we did that. And we looked into ice cream headache in patients with migraine, and we got 100 controls. In those days, orthopedic patients were hospitalized if they had fractures, and so they were lying around doing nothing.
Right.
Were happy to talk to us, so we had controls for both ice cream headache and for this postural visual syndrome, which turned out to be fairly specific for migraine. It was very rare in the controls.
Wow.
Yeah. So I use that in my history taking quite a lot.
Any thoughts regarding teaching, as now it appears technology is taking the place of traditional diagnostic approaches?
The teaching that I like to do for residents has to do with the details of the history. That when you talk about spreading numbness in migraine, I want to know whether it spreads from finger to finger. Miller Fisher said, that's migraine.
Yeah.
Numbness spreading finger to finger. Spreading up the arm, skipping the neck, landing on the face.
Yeah.
And if it involves the tongue, that's migraine.
Migraine. I like that. So now what do you think about the future of the field and the plethora of therapies available and becoming available to help our patients with migraine and other headache disorders?
I think the very fact that now that we have a new generation of medicines to offer people, the CGRP drugs, I think is a great step, comparable to the triptans entering the field.
Yes.
Expanding the scientific base of migraine with what I hope will be a group of drugs that will transform these chronic sufferers who haven't responded to anything else to get them greatly improved. I think that will get more people of scientific bent into the field. And so I'm therefore hopeful that there'll be more and more scientific hypotheses generated after this. I'm hopeful.